Thank you again. And well, I'm a radiation oncologist, so I'm really glad that there are a lot of cardiologists in the session. But of course, I can only report on the radiation oncology part and not on the cardiology part. And I will try to summarize the clinical indications and the problems of the target delineation for the cardiac radiosurgery. So as we already heard in the introduction, this is a new therapy option for patients who have no any other options for an invasive ablation of a ventricular tachycardia. These are very, very sick patients, so a little bit similar to a palliative situation to the oncology. And we know from animal experiments and also a lot of works from Oliver Blanc and other groups that stereotactic radiotherapy can induce changes in this myocardial scar, which can then stop these arrhythmias. So it is quite the marriage of two fields of cardiology and stereotactic body radiation therapy, which has been improved in the last 10 to 15 years in the oligometastatic situation, or for example for stage 1 lung cancer. And from that fields we have a lot of experience on technical workflows in this field. So there are now quite a lot of reviews from 2020 and 2021 regarding the series which have been published until now. So these are probably the 4 most important series of cardiac SBRT, the Washington University or Ostrava or Lausanne. They are all quite similar in number of patients, 10 to 19 patients in patient age. All of the patients had some kind of cardiopathy and left ventricular ejection fraction changes, and the treatment has been completed either on linear accelerator or CyberKnife systems with small PTV margins. And the PTVs were quite different in all of these series. The PTV volume, the dose was between 22 and 25 gray in 1 fraction, and the toxicity was acceptable or mild. And all series have reduced the VT burden. So here is, for example, one series from Ostrava, from Czechia, which has been published in 2019, where we see that the VT has been reduced after radiosurgery. So it was one of the first cases where we could see an efficacy, and the toxicity was quite low in this series. The most known paper or publication was from the Washington group, from Kukulic, in the New England Journal of Medicine, where the same results have been published. So the VT episodes could be reduced with cardiac radiosurgery, and they also published some histological changes after radiosurgery, and then follow-up CT imaging after 3 and 12 months, where we can see as an only small side effect radiation-induced pneumonitis, which is then disappearing after 12 months. We have the prospective data published by the Washington group, the ANCHOR VT trial. They included patients with more than 3 episodes of VT and with minimal 1 unsuccessful catheter ablation. Patients were excluded who had a very short life expectancy or polymorph VT or fibrillation. They apply 25 Cray, a small GTV, and a 4D CT and ITV concept, and ask after the efficacy how many VT episodes can be detected, ICD shocks, and the overall survival. They have shown 1 year overall survival of 72% and 3 deaths due to VT relapse. The toxicity was acceptable. However, they have seen some pericarditis, pericardiac effusions, and also the pneumonitis, but the efficacy was quite good. So the VT episodes could be reduced after stereotactic radiosurgery. So their coronavirus just stopped us a little bit. So this slide is from Boris Rudic, our cardiologist in Mannheim. So we did a Pubmed-search on SBRT or STAR treatment, and we see that there has been a little bit of probably due to coronavirus, a reduction of invasive ablations in 2020. So there is no talk without coronavirus this year, and this also we also felt it in the recruitation of the radioablation trials that the patients counts really went down last year. So, but if we look at all studies which have been published now, the clinical indications can be summarized for repeated VTs, which do not disappear despite of a maximal anti-arrhythmic therapy, and patients had at least one unsuccessful radiofrequency ablation in an experienced center, or they have contraindications for invasive ablation, for example, mechanical valves or intracardiac thrombi. The VT has to be documented in a 12-channel ECG, especially for large scars, and it has an electroanatomical mapping, invasive or non-invasive, has to be available. So this is the German trial designed by Dr. Blank, speaking after me. So it's a radiosurgery for ventricular tachycardia, preclinical and clinical evidence, and study design has been published last year. In this study, patients can be included whose life expectancy is at least 6 months, who have ICD, have a symptomatic monomorphic ventricular tachycardia, which require ICD interventions, and who are refractory to antiarrhythmic medication in a maximal dose. And here the inclusion criteria either VT recurrence with at least 3 episodes within 3 months, or the VT is inducible by ICD with a non-invasive program stimulation, or C, both. And the study is a kind of safety trial. So the first patient will be enrolled, and then the follow-up is done very frequently, especially in the first half year. So we see the patients very frequently and monitor the side effects, the serious side effects. And the next patient can be included if there was no serious side effect in the last patients. And data safety monitoring board is just controlling the methods and the results. So now there is also a new European Union online platform. It's called StopStorm, where these cases can be collected, so that it's a standardized treatment and outcome platform in a framework of a multidisciplinary consortium. So the German study patients will be also part of this European database. So now it's probably more interesting how can we perform this therapy. So the first thing is that for the radiation oncologist, that the contouring of the organs at risk is a bit more more complicated as, for example, for a lung SBRT. So we have to learn more about the heart, and we have to learn to define the cardiac substructures and contour the cardiac substructures, all coronary arteries and the atria and ventricles and big vessels, and also the parts of the left ventricle. So, for example, in the Stop-Stomp Consortium, 4 hours are thought to be adequate for one case for contouring these substructures. And then we come to the most important question: how do we define the target of this ablation? And there are, of course, 2 parts of this. So it's a real interdisciplinary work with the cardiologists. So first, the cardiology colleagues really have to say where we should ablate. And if I understand well, as a radiation oncologist, there is also a discussion in the cardiology fields, what is the optimal target for the invasive ablation. So there is, for example, this study which compared in a randomized manner for patients in ischemic cardiomyopathy, if it's better to ablate the whole scar or if it's better to ablate the substrate only. And they received better results with substrate based ablation. So it's a discussion, and if we discuss with cardiologists, then we always have the feeling that that field is also an improvement in the cardiology. So the first step is to define for SBRT the scar or border zone, and mostly the whole scar is too large to irradiate. So until now, in the published studies, the mean volume of the target volume was 70 cubic centimeters, but up to a maximum of almost 300 in the Robinson data. And they also have shown in the ASTRO last year that too large target volumes were associated with worse overall survival. So probably we have to reduce the target volume to a reasonable size to reduce also toxicity. So how can we define the targets? There are, of course, methods which are available in each country and which are absolutely necessary to be able to define the target. So, for example, the 12-channel ECG and the electroanatomical mapping. However, there are additional radiological methods, so the cardiac CT, the cardiac MRI, PET-CT, SPECT, or special functional MRI imaging, which, if available, can be, of course, included to the target volume definition and can be helpful for that. And then we have, of course, if we once defined this target volume and the electroanatomical mapping, and we really have the cardiological target, then we have to transfer it to the radiation oncologic planning CT. And this is a step which is still very hard to do, because we have a wish list, and it would be nice if we had it, but it's probably the work of the next few years to have this wish list. So we would like to integrate all imaging and functional modalities to the treatment planning system. We would need an optimal matching of all imaging modalities with the planning CTs. We need the same slice thicknesses and the orientation. So, for example, if I say a cardiologist, I have an axial slice, he understands something completely another thing as the radiological axial transversal slices. Then we would need the same motion phase, and with that, the same cardiac volume. So there are really many technical issues, which I think Oliver will also talk about in the next lecture. And what was the reality until now? So how have the target volumes have been designed in the studies until now. So our studies have 12-channel ECG and electroanatomic mapping data. The 3D imaging is mostly only CT. So for example, in Germany, on this electroanatomical mapping, then some kind of contouring occurs, and then on the CT also cardiac substructures have to be contoured, and then this contour has to be somehow transferred to the CT, which has a completely different orientation. And it is really an intellectual process to do that transfer. You can use the help of the distance of surrogate structures, for example, valves or aorta, coronary arteries, or the septum. And it's an interdisciplinary procedure together with the cardiologist and radiation oncologist and physicist. And of course, you can correlate it to the 17-segment model. And at the end, the consensus has to be found. So in the framework of the ENCORE VT study, they have used the 17-segment model more strongly, as we do in Europe. And in this year, also a Red Journal article has been published how these segments can be translated to a 3D CT anatomy. So if the cardiologists say, okay, just irradiate segment 5, then you can find segment 5 based on this atlas on your planning CT. This paper is from the group in Ostrava, and it's very interesting. It's just a case report, but they report stereotactic radiosurgery, which has had to be repeated in one patient because the first SBRT session failed. After the failed SBRT session, they subsequently remapped the patient then they remapped the scar, and they think that the targeting was some kind of incorrect due to the integration of the data from the electroanatomical mapping system, and probably due to by a better target definition, probably the second SBRT session has not have been necessary. So it was also an alarming paper to tell how important the targeting is and how important it is to try to integrate the electroanatomic data in the planning system, probably automatically, to avoid human errors. So we did a small contouring benchmarking for the RAVENTA trial. So we just took 3 in Germany and 1 in Switzerland treated cardiac SBRT cases with all data which were available. So the epicrisis of the patients and the ECGs and the electroanatomical mapping data and the imaging data. And we sent out these data for 5 centers and with all information. And the task was for all interdisciplinary teams that they should contour the clinical target volume for an SBRT on the electroanatomic mapping screenshots, and they should generate a CTB on the planning CT. And then we received these structures back together with the planning CT. Afterwards, all cases were discussed. We tried to do a consensus finding, and we compared those structures. And for the first question was on the cardiologists, which were the most important information which they received retrospectively. And already here we could see that the cardiologists were really having different approaches. So some cardiologists told that for them it was absolutely the electroanatomical mapping which was the most important information for their decision. But some other cardiologists found the 12-lead ECG more important. If we looked at target localization anatomically, or the segments the cardiologists wanted to target, that there was also a bit of differences between each centers, and there were also the structures which should be avoided during contouring. Some wanted to spare the coronary arteries or epicardial areas, so there were quite user-dependent differences already in the cardiologic decisions. And from that, it's, for example, a case that was the most concordant case, our third case, where I also presume that we had already a bit of learning effect or learning curve. Up there you see the contours and the electroanatomical mapping. So here we were quite fine, all 5 centers defined similar regions. However, we see differences in the size of the target volumes, and then all centers have to contour it in the CT. And here we see each with the different colors, the contours of the 5 different centers. And what you see, well, each center targeted almost the same region. However, there were substantial differences or some kind of visible differences, which can be seen the best on the 3D reconstruction, where, for example, a craniocaudal shift in the target volume can be observed between the different centers. So at the end, after really intensive discussions, we over all 3 cases tried to find a consensus structure, which has been selected as a fusion of the 2 most appropriate structures. And then we tried to put the differences of these structures in numbers. And this was based in just a structural analysis, which you can also read in a lot of radiation oncology papers where, for example, target volumes or any structures are compared. Basically, the volumes, the localizations, and other for example, surface distance of the different structures, and the DICE index has been compared. So if a structure is identical to the other, then it has a DICE index of 1, and if it's smaller than 1, it's some kind of differences. If we look at, for example, the third case, which was the most accurate or the most similar between the cases, we still see that the DICE indexes are in some centers more than 0.7, but however, there are some centers with so very bad similarity in these indexes. So I think the conclusion from this paper is that it's really hard to define a target volume, and there are a lot of things to discuss. And at least for the step of the transfer of the target volume from the electroanatomical mapping to the planning CT, we need an automatic tool to avoid the human error for the transfer. So that's what I wanted to show. There are some tools which have been already published for this purpose. So it's also another German group who published a slicer, which can load an electroanatomical map to a 3D slicer, and then it can be aligned with on the surface with a segmented left ventricle, and then the target volume can be then defined kind of automatically. And a software is being developed by Professor Schweikart in Lübeck in Germany, who is working together with Oliver. Also for the automatic registration. So you see here, this is a MATLAB-based software where you can see in red the contour of the left ventricle, and as a surrogate structure the aorta. and in blue, the electroanatomical mapping data, which can then be matched based on the anatomy. And then the target region can be transferred automatically. So we looked at our first case. We treated in Mannheim. So the cardiologist wanted to treat quite a large region in segment 4, imaged on this 17 segment model. And we did a planning CT in deep inspiration breath hold to reduce the breathing motion. We registered it deformably to the cardiac CT, which then ensured the easier contouring of the cardiac substructures. And then we received help in the transfer of the structures from the electroanatomic mapping. So this is, for example, a 2D transfer from the electroanatomical map screenshots on the CT, which is just a line which can then be from which you can create a 3D structure transmurally and manually transfer it to the CT. And this was the result. You can compare. We did first the structure with this intellectual manual transfer, and afterwards with this automatic transfer. And you see we were not that bad, but there are some small differences, especially here in the craniocaudal and left-right direction. So we then corrected our CTV, and there's also possible complete 3D, so mesh, based on the mesh data from the electroanatomic mapping, a transfer of the target volume and the planning CT, which we again compared the 2D transfer versus the 3D transfer. So this patient then was irradiated basically based on this target volume, which we created by this automatic transfer. We used just a VMAT plan and cone beam CT and imaging and treatment in deep inspiration breath hold. The treatment was quite long. The patient was lying on the table about 60 minutes due to the repeated breath hold needed, but he managed it fine. He is also fine now after now more than 2 months after treatment. He doesn't have any toxicity except a very small pneumonitis just adjacent to the PTV in the lung. But that will be probably also a regradient in the next CT. So that was our first case which we treated. And I just like to thank for the invitation again, and of course for the whole RAVENTA team, especially Oliver. And I think I will then pass it to Oliver and be ready then for the questions afterwards.